Good morning, everybody. Good morning, everybody. వినిపిస్తుందా లేదా ఒకసారి చెప్పండి. వినిపిస్తుందా లేదా ఒకసారి చెప్పండి. క్లాస్ వినిపిస్తుందా లేదా? Am I audible? Please message if I'm audible or not. Good morning, everybody. So today we are going to good morning, everybody. And today now we are going to continue from where we have left in the last class, benign bone tumors. So can any one of you tell at which point we stopped the lesson in the last class? Probably about 4 weeks back. We were discussing benign bone tumors. We have finished benign bone forming tumors, and then we have started another section. So can any one of you tell where we have stopped in the last class? So it has been a long time. So now let me start with the point, with the topic straightforward. Okay, now let us start with enchondroma. Enchondroma is another cartilaginous tumor. It is a solitary benign intramedullary tumor which is composed of mature cartilage. Please note it is mature cartilage, and most commonly it is found in the short tubular bones of hands and feet. That is mostly it is seen in phalanges and sometimes in metacarpals and metatarsals also it is found. And it accounts for 1/4 of all bone tumors. And if the question comes, what is the most common primary bone tumor of the hands? The answer is enchondroma. And enchondroma is most commonly seen in the proximity of the epiphyseal plate. So, which is usually proximal part of the phalanges or distal part of the metacarpals. Even though it is formed initially in the proximal proximity to the epiphyseal plate, gradually as it develops, it completely occupies the diaphysis sometimes. And the process of the tumor growth usually starts in the early age, and by the time it is symptomatic or when there is a considerable swelling, it will be around 2nd to 3rd decade. And till now, what all tumors we have seen, we found a few common points. One thing is most of the tumors are male predominant, and most of them are found in first 2 decades of life. Whereas one small difference and most of them are in long bones. Long bones, usually distal femur. They are the distal femur, proximal tibia, distal radius. These are the most common sites still about tumors we have seen till now. However, differentiating features of enchondroma from the previous tumors are these things. They are most commonly seen in the hand, and then they are usually seen in 3rd to 4th decade. And coming to the sex preference, it is equal in both males and females. So these are the few differentiating points of enchondroma. So coming to the pathogenesis, enchondroma is nothing but it is a hematoma which is originating from an island of fertile cartilage which is detached from the growth cartilage. Previously we have seen osteochondroma where there will be some herniation of the physeal cartilage from the perichondrium, and which leads to the development of stalk. But here there will be separation of the growth cartilage and it is mature cartilage which we are seeing here. So this is detached from the growth cartilage, and from this island of fertile cartilage, the tumor develops. Enchondroma grows slowly, and like any hematoma, its growth potential usually is exhausted after attaining the skeletal maturity. And in adults, it undergoes necrosis by calcification. Usually, if enchondroma, if it is soft and without much calcification, like a chalk, it can be broken. Sometimes, and its consistency also varies. It is made of hyaline cartilage, and it is glistening white or bluish gray in color, as any cartilaginous tissue. However, if you find some myxoid component in the tumor, you have to suspect some malignant change in the enchondroma. And coming to the microscopy, these contain nests of chondrocytes, but the differentiating feature is they do not show cellular atypia. Please message me if you are able to follow it or not, because I don't know how far you remember the previously discussed things. Okay, shall I continue? So I'm now continuing. Coming to the clinical features, enchondroma, it is usually asymptomatic. Mostly it manifests as swelling in the hand. The patient presents to you with some painful swelling in the hand. Sometimes there could be some pathological fractures of enchondroma after which they present. And for any other reason, they will get an X-ray done. And on that, they can be found as an incidental radiological finding. So when do you suspect malignancy? There are few points. If there is gross increase in the size of the enchondroma, or if there is any pain without pathological fracture, then malignancy is to be suspected. And coming to the radiological features, enchondroma is a well circumscribed. Well circumscribed. If it is well circumscribed, what does it mean? Is it benign or malignant? I think the chat boxes are activated and you can type your message in it. As we have discussed in the previous class, if a lesion is well circumscribed, that is the zone, well circumscribed lesion, and there is narrow zone of transition here. That is differentiation between healthy part of the bone and diseased part of the bone. There is narrow zone of transition here, and the margins are also well demarcated. So it is a benign tumor. It is a well demarcated, well circumscribed, distinct area of rarefaction or lucency, which sometimes expands and deforms the bone. And sometimes as a result of either degeneration, necrosis, or in case of pathological fractures, during the healing process, we will find some calcifications appearing inside the tumor. So these are pathognomonic of enchondroma. And also please note that there will not be any sclerosis or periosteal reaction in enchondroma. Please remember this feature because there is another tumor which is lytic tumor called fibrous dysplasia, where you will find some slight sclerosis in the margin. We are going to see it further. So what are the features which are favoring malignancy? First thing is pain without pathological fracture, and then rapid increase in the size, more proximal lesions. That is usually, if the lesions, they are usually found in hand and foot. They are not usually malignant, but sometimes if it is found in long bones or more proximal, then there are chances of malignancy. And this enchondroma also occurs as syndromes like Collier's disease and Maffucci's syndrome, where there is chance of malignant transformation. So these are the different X-ray pictures. Here you can see this is a well circumscribed lesion, usually closer to the epiphysis, and there is a pathological fracture across the bone. And this is malignant potential. It has transformed into chondrosarcoma. You can see that the size has enormously increased. The cortical lining is also not preserved, and you cannot really appreciate the zone of transition between the healthy bone and the normal bone. It is looking very aggressive. So the malignant form of enchondroma is chondrosarcoma. Malignant form of osteoblastoma is osteosarcoma. Osteoid osteoma, it has less potential, it has very rare or no cases of malignant transformation, whereas osteoblastoma, it transforms into osteosarcoma. So these are for comparison I am telling, please remember these things. And coming to the treatment, if the tumor is asymptomatic, just you observe for any malignant change in the tumor periodically. If the lesion is symptomatic, that is there is pain or swelling or any obstruction to the joint movement or anything, then curettage is done and bone grafting is done to strengthen the bone. And after curating, the walls should be treated with either burring or with phenol, because to reduce the recurrence rates. Suppose a pathological fracture is already there, you have to wait till the fracture is healed, and then when the cortical continuity is restored, then you should go for curettage and bone grafting. So these are the treatment modalities of enchondroma, which is a well circumscribed lytic lesion, usually found closer to the epiphysis, and sometimes it may occupy the entire diaphysis, and which is most commonly found in hands, most commonly seen in second to third decade, and equally seen in males and females. So this is all about enchondroma. And few syndromes, these are important for your entrance examination. One thing is Olier's disease or dyschondroplasia, which has multiple enchondromatosis. With multiple sites you have enchondromas. If the same thing is associated with hemangiomas, then it is called Maffucci's syndrome. Both these things, unlike enchondroma, are more in males, and usually unilateral involvement, one side of the body is involved. However, if both sides of body is involved, then there is chance of malignant transformation. In such multiple enchondromatosis, the chances of malignant transformation is as high as 30%. And because multiple areas are involved, sometimes if epiphysis is involved, there will be some deformity or bubbling of the legs, and shortness of the limbs are present. So these are the X-rays of Olier's disease, where you can see multiple lesions, multiple enchondromas. So here also you are seeing multiple enchondromas. I am pointing out with the cursor. So this is also an X-ray of Olier's disease, where you can see multiple enchondromas, and the bubbling of the bones can be appreciated, and there is shortening of the limb is also present here. So I want you to respond. Did you understand so far what was told? What was told here? What was discussed here? Please respond, because the chat box is allowed. Please message if you are getting it or not. Then coming to the next benign cartilaginous tumor, it is chondroblastoma. Since it was first described by Codman, it is called Codman's tumor. And please note here, this is a primary benign tumor which is arising from the immature cells of the epiphyseal cartilage. It is located in the epiphyseal region. Two tumors which are located in the epiphyseal tumors benign are chondroblastoma and giant cell tumor. So here it is from immature cells, it is arising. It is arising from the immature cells, whereas enchondroma from the mature cells. It is most common in first 2 decades of life and more common in males. Upper end of the humerus and tibia are the common sites which are involved. So usually it is an incidental finding. Sometimes since it is closer to the joint, the patient may have features of synovitis, like joint pain and swelling will be present. Pathological fractures are extremely rare. It is a lytic lesion with well-defined margins, usually seen in the epiphyseal region. Fine calcifications may be seen. Sometimes slight scalloping or expansion of the cortical bone may be present. But usually it doesn't breach the physis, it doesn't open the physis, and periosteal reaction is also not seen. But if they are seen, it indicates the aggressive nature of the tumor. And coming to the pathology, chondroblastoma is made up of friable soft grayish pink tissue intermixed with gritty calcified and cholesterol laden tissues. There will be some hemorrhagic areas and cystic areas. Coming to the microscopic feature, there are polygonal shape of chondroblasts, which are the predominant cells, and occasionally there will be some giant cells present between them. Surrounding this polygonal chondroblast, there will be pericellular calcification. This pericellular calcification gives the appearance of chicken wire appearance, which is asked as a fancy question in your viva, or it may be asked as a PG entrance bit also. They may explain the histological features of the tumor giving chicken wire appearance. Then you may have to identify the tumor. So that way, chicken wire appearance is characteristic of chondroblastoma. So this is the appearance, though chicken wire calcification is not so clearly seen. This is the histological appearance of chondroblastoma. Then coming to the treatment, curettage with adjuvant liquid nitrogen or phenol or mechanical burr is the preferred treatment. And en bloc excision can also be done if the location of the lesion permits it without compromising the neighboring joint. If the joint is not involved, even en bloc excision can also be done. And then coming to the next tumor, it is chondromyxoid fibroma. In chondromyxoid fibroma, there will be some myxoid and fibrous elements also in the tumor. And it accounts for less than 1% of all bone tumors. Hence, it is extremely rare. And it is more common in males. Usually present in second to third decade and commonly seen in metaphysis. Sometimes it may expand into the diaphysis, and most commonly proximal tibia is involved. Usually it is an incidental radiological finding like many other benign tumors we have discussed before, and chronic pain is also one of the features. Swelling is seen when it involves some small bones. And coming to the radiological features, it is an eccentric lytic lesion. Eccentric lesion, lytic lesion, usually found in metaphyseal region. Sometimes it may expand towards the diaphyseal region, and there will be sometimes bite lesions in the cortex of the bone, and it may give appearance of two hemispheres as seen in this tumor. Here also you can appreciate small two hemispherical structures here. So there will be bite-like lesions in the cortex of the bone, and there will not be any periosteal reaction. So coming to the treatment, it consists of extended curettage or resection. Then if the curettage procedure it weakens the bone, then you may have to augment the bone with a bone graft. If the lesion is also present near the physis, then we may have to delay the surgical intervention till the tumor has grown away from the physeal area. And then one of the most important tumors, usually asked as either 4 marks question or sometimes even as an essay question, is giant cell tumor. Giant cell tumor is seen in skeletally mature individuals, and its peak incidence is in third decade of life, most commonly seen in females. And distal femur and proximal tibia are more commonest sites involved, followed by distal radius. It is an epiphyseal tumor which may extend up to the metaphysis region also, and the tumor will not breach the articular surface. I will show you when we discuss about the X-rays. It will grow up to the subchondral bone area, and this tumor was first described by Sir Ashley Cooper. So here, because of the tumor activity, the cortex, the outer cortex is thinned out, and ballooning of the cortex is present. I am showing with my cursor. You can appreciate that there is slight expansion or ballooning of the cortex is present, and because of these tumor cells, the cortex may get thinned out, So as the cortex gets thinned out while palpation, you will have some eggshell crackling, that is cortex slightly breaks while palpating the tumor. This feature, this clinical feature of eggshell crackling is appreciated only if the cortex surrounding the tumor is very thin. If it is not thin, even though the tumor, the in the textbook you read that there will be eggshell crackling, that will not be appreciated clinically. Why I am stressing so much is, suppose you come to know the giant cell case is kept in exam or for your examination, and you tell that you have appreciated eggshell crackling, it may not be present. So please be watchful. That finding is seen only if there is really thinning of the cortex. If there is no thinning, you will not appreciate eggshell crackling. So please note that. And the tumor is also gray to reddish brown in color, and it is composed of soft, vascular and fibril tissue. And there will also be areas of fibrosis and collagenization, and osteoid production may be found as a result of previous fracture or degeneration. And coming to the clinical features, there are multinucleate giant cells. So these have moved out. I'm pointing it out with the cursor. These are the, just below the circle, you can see that there is a multinucleate giant cell. Even here you can appreciate below the circle, there are multinucleate giant cells. So these are multinucleate giant cells which are present here, whereas the spindle cells or stromal cells, they are the aggressive cells. These are the cells which are characteristic of the tumor. And then ossification and osteoid production are also seen in small foci. And coming to the clinical presentation, usually seen in third to fourth decades, most commonly seen in females. This is one of the tumor which has benign bone tumor which has female preponderance. And another one is fibrous dysplasia, which we are going to see in the next few slides. Usually patient presents with pain and swelling. Sometimes they may directly present with a trauma or pathological fracture, may direct our attention to the site and lead to the discovery of the tumor. So now, here you can see that the tumor is, these are the features. One thing, it is epiphyseal, epiphyseometaphyseal in location, eccentric in location, and epiphyseal to metaphyseal in location. And then it is all expanding the cortex. I have told you 3 E's. One thing is it is eccentric, second thing is epiphyseometaphyseal in location, and then it tends to expand the cortex. 3 features. And the fourth feature is it may extend up to the subarticular bone. It will not breach the joint or physis usually. So one more important feature is it is found in mature skeleton. Till now, most of the tumors what we have seen are in immature skeleton, and upcoming tumors also you have unicameral bone cyst, aneurysmal bone cyst, which are seen in immature skeleton, whereas this one is seen in a mature skeleton. Mature skeleton. And because you may have a case of GCT in your exam, or sometimes even the X-rays can also be kept. So please note the radiological features. They are eccentric, expanding the cortex, epiphyseometaphyseal in location, and expand up to the subchondral bone. So these are the radiological features. Most common sites are distal femur, proximal tibia, distal radius. And in this I am showing another important radiological features. You can see that there are fine trabeculations in the bone. So these trabeculations give a sort of soap bubble appearance. Soap bubble appearance. It is an eccentric lesion because since it has grown in size, it is looking as if it is central in location. But a GCT, as you have appreciated in this X-ray, is eccentric. Eccentric expansile, expanding the cortex, thinning the cortex, and giving a soap bubble appearance. and usually there is no mineralized bone matrix in it, tumor matrix in it. So, and it extends up to the subchondral bone. So these are all the different radiological features of GCT. And now coming to the treatment, as in any other bone tumors which we have seen now, curettage and bone grafting. We have been telling so. So the recurrence rate of GCT is as high as 60%. It is as high as 60% if you just do curettage and bone grafting. However, there are certain things you may have to use some adjuvants like phenol or liquid nitrogen, which is one option. And then there is another option where you fill the cavity with bone cement. If you fill the cavity with bone cement, there will be some exothermic reaction as the bone cement hardens, which kills the residual tumor cells after curating. And even if there is an occurrence of recurrence, it can be easily identified if it is cemented. So this, just please make a note of it. This cementing technique of the GCT is called sandwich technique. Sandwich technique, you can call it sandwich technique. Why? Because you place the bone cement and then you will keep some gel foam, and over the gel foam you will keep some autographed bone pieces which is taken from another side. This is done because, as we have told, that this bone cement causes exothermic reaction, and you fill it up to the subchondral bone. You suppose the tumor is extending here till the subchondral bone. If you fill it up to this point, this exothermic reaction may damage the articular cartilage. That's why you have this gel form technique, sandwich technique is used. Here for stability of the bone, some fixation is also done. So this is all about GCT, and one more small point which I want to add is there is a grading called Campanacci grading in GCT. So as the grade advances, there are 3 grades. This is beyond the scope of your subject discussion, but to be on safe side, it may be asked in some entrance or any quiz. So that's why I'm just telling this classification name. Remember the name, Campanacci classification. And here, there are 3 grades: grade 1, grade 2, grade 3. As the grade increases, the aggressiveness of the tumor increases. There will be breach in the cortex, and the size of the tumor will also be increasing. So please remember the name. So now we are going to cystic lesions of the bone. Here under the cystic lesions, we are going to discuss about unicameral bone cyst, aneurysmal bone cyst, fibrous dysplasia, and ossifying fibroma or adamantinoma. So these are the 4 things which we are going to discuss here. Coming to the unicameral bone cyst, it is most commonly seen in first 2 decades, male preponderance. And please remember that UBC, one of the hypotheses for development of UBC is developmental anomaly of physis, where there is transient failure of ossification of physeal cartilage, and as a result there will be cyst formation. Initially it will be closer to the physis, and with the growth it moves away from the physis towards the diaphysis. So active cysts, where the growth potential of the cyst is more, those active cysts are very much closer to the physis. Juxtaposed to the physis means they are closer or towards the physis. And latent cysts, these are the cysts which are located away from the physis. And the most common sites are proximal humerus, proximal femur, and anterior aspect of the calcaneum. So these are the common locations of unicameral bone cyst. And coming to the pathology, it is of immature skeleton. Unlike the mature skeleton in enchondroma, it is seen in immature skeleton, and then it has benign fluid-filled cavities, and they tend to expand and weaken the local area. Usually, histologically, these cavities, they are filled with some prostaglandins and prostacyclins and other materials which lead to the destruction and expansion of the surrounding bone. And when you aspirate the cyst, you will find thin yellowish fluid which is usually sometimes blood tinged. The cyst wall here is composed of fibrovascular tissue with giant cells and reactive bone. Please remember the fluid here is thin, usually yellowish in color, sometimes blood tinged, maybe appearing. And then in long-standing cases, there will be cholesterol clefts and macrophages with hemosiderin deposition are seen. UBC usually presents with a pathological feature. Usually it is noticed after trauma, and on examination there will be slight warmth and swelling. When the fractures become evident, they rarely involve the growth plate itself. Sometimes diaphyseal cysts also can occur. Why diaphyseal cysts can occur? As we have seen, the active cysts become the latent cysts. They grow from the metaphyseal area to the diaphyseal area. So, UBC is a benign cystic lesion of bone which is well marginated, centrally located tumor. You may confuse it with you may get confused with other tumors. That's why I'm emphasizing more on radiological features. This is centrally located, whereas GCT is eccentrically located. It is seen in GCT is seen in mature skeleton, whereas UBC is seen in immature skeleton. And here I am showing this is a lytic lesion, which common features are it thins and expands the cortex. And it is centrally located tumor, UBC. And then here you can appreciate one thing. There is a fracture here. I am showing it with the cursor. So here you appreciate some fracture, and that comminuted piece of fracture has fallen into the cavity. I am showing it with red color here. So this sign is called fallen fragment sign. This is the fallen fragment sign. It has fallen down here, so it is called fallen fragment sign, which is the pathognomonic of UBC. So coming to the treatment, if asymptomatic, it can be left. Otherwise, in larger lesions or symptomatic lesions, then it has to be treated. If there is risk of pathological fracture, you should curate the bone and then fill it with a bone graft and do some internal fixation. See, please remember, internal fixation is done in bone tumors to provide stability to the bone. It will not interfere with the disease process or pathological process. It is only to provide stability to the bone. We are using internal fixation here. Sometimes in some lesion you can aspirate the fluid which is inside the unicameral bone cyst and inject it with some corticosteroids like methylprednisolone, or bone marrow aspirate, or some demineralized bone matrix. Different materials are used. It can be injected into the cavity. It heals. Or sometimes it may heal by itself with gradual bone formation. So coming to the treatments, it is either curettage with bone grafting and internal fixation, or aspiration and injection. So these are the modalities of treatment in case of unicameral bone cyst. And coming to the next one is aneurysmal bone cyst. It is also a solitary lesion seen in metaphyseal region of the long bones. And it is usually seen in the first 2 decades of life. And one hypothesis is, following a trauma, there could be some formation of arteriovenous malformations in the bone, which may result in this swelling. And main clinical features are pain and swelling, and it may be associated with pathological fractures. It is most commonly seen in long bones and pedicles and laminae of the vertebra. Vertebral involvement is seen. Till now, we have also seen this in osteoblastoma, where vertebra is involved. Pedicles and lamina are involved tumors which we have discussed so far. You can see this involvement of pedicles and lamina in osteoblastoma. And now again you are seeing it in the aneurysmal bone cyst when we are discussing about it. So coming to the radiological features. It is a radiolucent, ballooned out, eccentric lesion in metaphyseal region with thin shell of cortical bone covering the lesion. So most of the radiological features, they are resembling that of GCT. GCT is also a lytic eccentric tumor. This is also eccentric tumor. Since it has grown very much in size, it appears like this. And there will be ballooning of the cortex. And another thing is, you can find some trabeculations, small trabeculations in this aneurysmal bone cyst, which are also seen in GCT. So the difference is, aneurysmal bone cyst is, it is most commonly seen in immature skeleton. See, the physis has not closed completely. Even in this skeleton also, in X-ray also, the physis is not closed. And predominantly this is a metaphyseal tumor, whereas GCT is an epiphyseal tumor. Epiphysis extending into the metaphysis. And GCT is seen in mature skeleton. Aneurysmal bone cyst is seen in immature skeleton. So these are few differentiating features of GCT and aneurysmal bone cyst. Why I am emphasizing more on this radiological features is, these X-rays can be kept in your examination as a part of viva, or sometimes you may get a case also directly, short case. Then you will be discussed all these things. So grossly, it appears as a honeycomb of blood-filled cavities lined by fibro-osseous cystic tissue. The difference between UBC and aneurysmal bone cyst is, there you have serous to yellow tinged fluid, yellow color fluid, which is sometimes blood tinged. Here you have blood-filled cavities. So that is one thing. Then there are fibrous tissue septae, which are separating. These trabeculations are seen in ABC, aneurysmal bone cyst. They are not seen in UBC, unicameral bone cyst or simple bone cyst. So coming to the other features of ABC, microscopically there are multiples of giant cells, xanthoid cells, and altered blood pigments are seen. And coming to the treatment, it is surgical curettage, bone grafting, and stabilizing the bone if necessary. And now coming to the third benign cystic lesion of the bone, which we are going to discuss, it is fibrous dysplasia. It is nothing but an intrinsic defect of enchondral bone maturation. It results in some incomplete or immature ossification patterns. And basic thing which you have to remember is, the tumor is basically characterized by benign fibrous trauma. Benign fibrous trauma intermingled with some bony islands of metablastic bone. Because there is fibrous component increased, there will be some structural weakening of the bone, and as the bone weakens, it results in pathological fractures. So coming to the classification, monoosteotic fibrous dysplasia, that only if a single bone is involved, it is monoosteotic fibrous dysplasia. If multiple bones are involved, it is polyosteotic fibrous dysplasia. There is one thing called McCune-Albright syndrome. It can be asked as a 2 marks question in your university exam, and it is also an important PG bit. So in McCune-Albright syndrome, you have this polyosteotic fibrous dysplasia with endocrinal abnormalities resulting in precocious puberty, and capillate spots are also seen. This triad is called McCune-Albright syndrome. So most of the cases, they are asymptomatic. However, 70% of cases, they may present with bone pain. And if at all any skeletal deformities are to develop, they develop by the age of 10 years, but they may develop subsequently also. And one feature of fibrous dysplasia, which we have not seen previous in unicameral bone cyst and ABC, is there is increased risk of developing secondary sarcomas, usually osteosarcoma. So coming to the pathology, we have seen that there will be fibrous trauma predominantly with some metaplastic bone islands. So in collaboration with that statement, you can see in pathology that it consists of poor thinly oriented fibrous osseous structures with osteoblastic lining, and there will be fibrous trauma. This arrangement of osseous trabeculae reminds us of Chinese letter characters. So Chinese letter pattern is seen in fibrous dysplasia. So this is one of the features, fancy term which is used with relation to fibrous dysplasia. And sometimes there will be small foci of cartilage, hemorrhage, and osteoclastic giant cells may be seen. Location, it is like any other till now we have seen, it is metaphyseal and diaphyseal location as we have seen in cystic lesions of bone. It can be either centric or eccentric. Whereas the destruction is geographic type of destruction. And the matrix seen is ground glass matrix with some intramedullary lucences which is hazy in quality. So this is in early immature skeleton. You can see that there is a lytic lesion with some lucences in it, hazy lucences you can see. And it is seen in metaphyseal to diaphyseal in location. So, and now because it is a weight bearing bone, femur is a weight bearing bone, and because of the fibrous trauma there will be excess forces acting on the femur which has led to the deformity of the bone. See, this is called a shepherd crook deformity. And now coming to the treatment point of view, monoosteotic lesions which are asymptomatic can be left. And surgically they are intervened if the deformities like shepherd crook deformities are increasing, or if there is any fracture which has gone into non-union, and femoral shaft involvement, if there is femoral shaft involvement. And then if there is persistent pain, we have to intervene surgically, which is usually curettage, bone grafting, and internal fixation to augment it. Sometimes bisphosphonates are also usually also have a role in the treatment of fibrous dysplasia. With respect to fibrous dysplasia, there are few important points which you have to remember. One thing is usually seen in females. And this McCune-Albright syndrome, you have to remember about it. And then this Chinese letter configuration in the histological appearance, and then ground glass matrix type of appearance, shepherd crook deformities and other deformities you have to remember. These are some of the salient features of fibrous dysplasia. So coming to the last topic, ossifying fibroma or adamantinoma. Ossifying fibromas, they are nothing but well-described monoosteotic lesions seen in early age. Usually tibial shaft is most commonly involved, and mandible is also involved. Seen in first and second decade of life. Pain is the first symptom, swelling is also seen. Here you can see, which is a radiolucent lytic lesion with confluent ground glass or vacuolated appearance. Seen in diaphysis or metaphysis, there will be expansion of the cortical bone, and sometimes it may be removed by the reactive bone. And coming to the treatment, you have to observe by serial radiographs. If there is any increase in bowing, anterior tibial bowing, bracing is required. And if the bowing is increasing and if there is any impending pathological fractures, or then you have to intervene surgically by complete excision and with bone grafting and internal fixation. So this is all about adamantinoma. Now, a few points which I would like to highlight is, these are important for your entrance point of view. They may be directly asked in your exams. And most common bone tumors are secondaries. And most common primary malignant tumor of bone is multiple myeloma, followed by osteosarcoma. And commonest malignant tumor of flat bones is chondrosarcoma. Commonest true benign bone tumor is osteoid osteoma, and most common benign tumor of spine is hemangioma. And please remember, I want to brush it once again. Benign bone tumors, they have well-defined margin and uniform consistency on field, and there will be on X-ray, you will appreciate a well-defined margin and narrow zone of transition between the diseased bone and the healthy bone. Whereas malignant bone tumors, they have ill-defined margins and the zone of transition is very wide. Coming to the destruction of bone, in benign varieties, there will be geographic destruction. In malignant or aggressive tumors, as the aggressiveness of the tumor grows, they are either moth-eaten or permeative patterns of destruction are seen. So in this class, we have finished benign bone tumors, and in subsequent classes, malignant bone tumors will be dealt. Now, there is a small question which I am going to give you. So please answer this question. You can reply in chat box. I'll give you 2 minutes time. So you read and type your answer in the chat box. So here the question is, a 12 years male patient complains of a painless bony heart swelling which is arising from the left femoral metaphysis. The swelling has a well-defined margin, uniform consistency. So, and then has a stalk of connection with the bone. It grows away from the knee. The swelling looks smaller on X-ray as compared to palpation on clinical examination. This swelling can undergo malignant transformation, most common of which is chondrosarcoma. So, by which of the following modalities you can appreciate the malignant change the best? A is MRI, B is CT, C is X-ray, D is histopathological examination. So very good. Someone has answered it very correctly. And 124. Okay. Okay, very good. I am getting responses. Please. So those who have given me answers, can you justify why you feel that so? 88 also has sent me the answer. So before justifying the answer, can you tell me what is the diagnosis? About which tumor is he talking about? So here in this question, there are 3 things which we have to understand. First thing is, what is the tumor? And why is it looking smaller on X-ray as compared to palpation? And third thing is, why do you choose that particular modality as a suitable modality of investigation? So the 3 parts of the question are apparent before us. So first thing is, let me explain it. Because the swelling is, it has given that it is a well-defined margin and uniform consistency, it is a benign bone tumor. And then it has a stalk of connection with the bone. So which are the tumors which are pedunculated till now, what we have seen? And it is growing away from the knee. The tumor which is growing away from the knee. Very good, very good. Answer is correct by roll number 124. So it is the knee. A tumor is arising from the metaphysis. It has a stalk. It is osteochondroma. And what do you have over this osteochondroma? I am drawing it with blue color. What is it? That blue color structure in osteochondroma. Please answer. What is the blue color structure? Which this blue color structure? What is it? Which cap do you have over osteochondroma? So let me finish. You have the cartilaginous cap. You have cartilaginous cap over osteochondroma, and that cartilaginous cap, it cannot be appreciated. So this cartilaginous cap, it cannot be appreciated on X-ray, whereas you can palpate it. That's why the swelling looks smaller on X-ray as compared to palpation. Even if you open the site also, it will be appearing larger than what is seen on X-ray. So serially, the thickness of the cartilage gap should be measured from one point of time to other. It should be less than 2 centimeters. If it is more than 2 centimeters, or if it is increasing in size even after attaining skeletal maturity, then you have to suspect of malignant transformation. Then what are the modalities used to measure the thickness of cartilaginous cap? One thing is MRI and other one is ultrasound. Ultrasound they have anyway not given in the question. So MRI is the modality. And one more advantage of MRI is you can detect involvement of medullary cavity if there is malignant transformation, whether the medulla is involved or not. And soft tissue invasion also, it can be appreciated on MRI. To measure the cartilage thickness, it is the best modality which cannot be appreciated well on CT, and in X-ray you cannot appreciate it. So understood everybody the question? So with this we have completed our lesson on benign bone tumors. If you have any queries, you can ask me now. There is still 5 minutes time left, or you can send your queries to the mail which I have typed in the chat box. So if you have no doubts, we'll end our session today. Thank you everyone.